what are the main therapeutic options when you are treating a patient with diabetic ketoacidosis. The mainstays of its management include the rehydration and correction of electrolyte abnormalities and treating the hyperglycemia. And also important thing is to correct the precipitating causes. So DK patients are severely hypovolemic with water deficit of about 100 ml per kg of body weight, and therefore fluid resuscitation is the cornerstone of therapy, is the first line of therapy of DK management. So initial IV fluid replacement starts with 0.9% sodium chloride at a rate of 15 to 20 ml per kg, that is about 1 to 1.5 liter over the first hour. Thereafter, the rate and type of fluids is determined by assessment of the clinical condition. In case of mild to moderate hypovolemia, the fluid administration rate will be 500 ml per hour for 4 hours, followed by 250 to 500 ml per hour. But in hypovolemic shock, higher rates of fluid up to 1 to 2 liter per hour should be given until hemodynamics is stabilized. Once hypovolemia is corrected, check the corrected sodium level. What is the corrected sodium level? So that is hyperglycemia usually causes the osmotic shifts of water from intracellular to the extracellular space, leading to relative dilutional hyponatremia. Therefore, actual sodium will be higher than the measured sodium from the lab, and a 2.4 millimole per liter decrease in the sodium level occurs per 100 milligram per deciliter increase in the glucose concentration. So that is your usual formula. And now if your corrected sodium is less than 135, continue with normal saline only. But if you see the corrected sodium is more than 135, then change to 0.45% normal saline. So that is what is flow chart about the fluid therapy. Once blood glucose reaches to less than 200 milligram per deciliter, you need to add 5% dextrose. Okay, so 200 milligram per deciliter is equal to about 11.1 millimole per liter. So if the blood glucose is decreasing and it reaches to 200 milligram per deciliter, you should add 5% dextrose, 2.45% sodium chloride at a rate of 150 to 250 ml per hour. Okay, so why do you need to add dextrose? To prevent the starvation ketosis, or to development of ketoacids formation, so that you need to prevent, and your target blood glucose level should be 150 to 200 milligram per deciliter. Insulin therapy is crucial line of management of DKA because it reduces the production of hepatic glucose, increases the utilization of peripheral glucose, and also inhibits the lipolysis and ketogenesis, glucagon secretion, resulting in lowering of plasma glucose and decreasing the production of ketoacidosis. The dose is as follows: the 0.1 unit per kg loading followed by 0.1 unit per kg per hour infusion. So you should monitor glucose monitoring. You should monitor glucose every hour and titrate the IV insulin accordingly. Your target reduction in glucose level should be between 50 to 70 milligram per deciliter, and you should follow this treatment line. If your decrement in the glucose, the rate of decrement in the glucose concentration is not as per your desired level, your desired target, then you should increase the rate of insulin infusion doubled, okay, so that you can get the desired reduction in the glucose level, that is 50 to 70 milligram per deciliter. That is very, very important for the management of DKA. Now the role of subcutaneous insulin in DKA. So in mild to moderate cases only, you should give the subcutaneous rapid acting insulin, and it is as good as the IV insulin. Suppose you don't have the IV, what you call IV line, then you can give subcutaneous or or intramuscular insulin in DK patient, provided this is just a mild to moderate case. So you know that electrolytes are lost in the urine because DK patient lose lot of urine. Therefore, and also due to insulin, potassium is shifted inside the cells, leading to hypokalemia. Correction of acidosis also leads to hypokalemia. So because of various reasons, hypokalemia occurs, and that is the reason you should check the potassium level every 3 hours. And if your potassium is between 3.3 to 5.2, then you should start infusion of potassium at a rate of 20 to 30 millicoolant per liter. And if your potassium is less than 3.3, then you stop insulin and then you continue the potassium infusion. That's very important. Before giving insulin, you should correct your potassium if your potassium is less than 3.3. Now the routine phosphate repletion, okay, as we used to do before, is now not recommended given the absence of clear benefit and its association with hypocalcemia. So we do not give for phosphate routinely until unless your phosphate level is quite low. Excessive urinary magnesium loss during acidosis and secondary to insulin deficiency leads to hypomagnesemia. That is why you should correct magnesium if your magnesium level falls below less than 1.2. In a randomized controlled trial, sodium bicarbonate used to treat acidosis in DK has not shown to have any impact on clinical outcome, and that is the reason we do not give the soda bicarb. If because this acidosis gets automatically corrected by giving adequate fluid and insulin therapy. That is the reason we should not give soda bicarb. Rather, in a systematic review, there was more harm noted, okay, and there was no evidence of any clinical benefit. So there are various side effects due to your bicarbonate administration. For example, volume overload, patient may develop severe hypokalemia, hypernatremia, and also your oxygen hemoglobin dissociation curve will be shifted to left side, leading to tissue hypoxia. So these are various complications of soda bicarbonate therapy, and in the trial it has not been shown to improve the outcome. So that's all for today. Kindly subscribe, like, and share this video. Thank you. Bye bye.